Hello, my name is Nahul Desai, and I'm going to talk about pulmonary arterial hypertension, the section of the NAPLEX review course. Um, this isn't really very much dealing with respiratory. You might see some of the relevance in the cardiovascular section as well. Um, so it kind of plays a role in both sides of it. Um, but some of these things overlap as well. So you'll see some topics um, kind of overlap each other. And you can see here, like we already talked about asthma, COPD, cystic fibrosis already. We are going to talk about now our pulmonary arterial hypertension. Um, you'll probably see maybe a few of these medications overlap from one topic to another. Um, but just be aware that um, the uses of how these drugs work is going to be slightly different from one disease state to another. Um, but let's look at this pulmonary arterial hypertension section right now. Some of you may have seen some of these medications in your pharmacy, um, but um, may be curious as to how they work. So we'll take a look at them in this section and what classes they belong in all. So let's see. So pulmonary arterial hypertension essentially just this might look like a lot of things here, but it's actually not. Um, think of arteries as blood going away from the heart. So when blood is going away from the heart, um, you can see on the left side in a normal heart, blood is flowing away of the heart, and then um, eventually it's going to go to the lungs and then get oxygenated and come back to the heart, and then goes from there. Same thing um, that has to happen, from right side, left side, they both work equally and everything. But when there's pressure built up um, in these arteries where blood is not being able to flow to like the lungs or to any other organ where blood needs to get delivered to, then it's going to um, affect the functioning of that organ as well. Um, and with the heart working harder, it might lead to abnormally high blood pressure and cause the right side of the heart to strain and eventually fail. So what happens here is the substances that help with vasodilation and vasoconstriction, like it just becomes abnormal. So like nitric oxide decreases, prostacyclin decreases, and then when those two are decreased, then there is a chance of um, a more vasoconstriction, and then it just really makes it hard for the heart to pump that blood out. So there's less vasodilation, more vasoconstriction in the smooth muscle. So smooth muscles are essentially those smooth muscles that line up in the heart, and so that blood can flow easily to the other parts of the body. And so um, this other diagram is just to give you some information as to what's being affected here when there is um, pulmonary arterial hypertension involved or high blood pressure in the heart um, of the smooth muscle. So you can see endothelial dysfunction, smooth muscle hyperplasia, and inflammation. Like any of these things can occur. So just wanted to show you a quick diagram here on that. Then this section kind of expands it, you know, to show you the picture a little bit further or a little bit better. The main things I'm going to talk about are the medications used to prevent vasoconstriction, like the nitric oxide, um, in helping increase nitric oxide, the prostacyclin, and also decreasing the endothelial or ET1. Um, so many times you see like nitric oxide, PGI2, and the ET1. These are the main three peptides, enzymes that are actually produced in the smooth muscles that to normally balance between vasoconstriction and vasodilation, pumping and relaxing of the smooth muscles so that blood can flow to the lungs. And so it's important to know the medications used to um, target those um, enzymes or peptides to prevent, um, you know, further exacerbation of um, this function of the uh, organ or the functioning of this smooth muscle. So let's take a look at some of the treatments, um, side effects, and all those things that may occur. So when it comes to vasoactive substance abnormality, you can see that the endothelin 1 increases, and then there's a decrease in nitric oxide and the prostacyclin. So this is just a quick diagram to show that. And so what are some of the symptoms I see described? Like there can be dyspnea on exertion, fatigue, chest pain. Um, it can affect the heart, cause lower extremity edema. Um, and because of the right heart working so hard to strain that blood out, it can lead to loud S2 heart sound as well, and right heart strain. So there might be signs of that. And so um, these are some of the treatments that are typically used to um, treat the functioning of the smooth muscle so that it can relax the muscles a little bit better for the blood to flow through. So you can see endothelin antagonist, meaning like it's going to help decrease the endothelin or ET1 enzyme. So you see here bosentan, ambrisentan, and baxentan. Now, before I get to that mechanism, I do want to mention that ambrisentan is a selective ET1 antagonist, and bosentan, maxitentan, sorry, is they are actually uh, um, antagonists for both uh, types of receptors. I'm going to talk about ETA and ETB receptors. There are two types, ETA and ETB. ETB is more so like, again, they are basically located in two different places. So basically, like ETB could be in receptors could be located in the blood vessels or the endothelium cells, and then ETB is also located on vascular smooth muscles. In this section, I'm going to just talk about vascular smooth muscles. So if they are targeting both, there is a chance it might also affect the ETB inside the vascular lining as well, like the vascular cells. So just keep that in mind. ETA is just going to be it's just going to be ambrisentan. A for A, and then bosentan for both. B for both. B for B. ETB. And then PDE5 inhibitors, we already briefly discussed it in the previous um, sections, but I'm going to explain it again very briefly. Then there's only one FDA approved medication here for us that helps in um, decreasing that vasoconstriction. Is the Real which is the soluble guanylate cyclase stimulator. So you could see the word stimulator here. So it's going to help increase or improve the growth of that enzyme or that drug so that um, it will work properly. So we'll take a look at that and how that helps. This is the one of those drugs where nitric oxide is involved. So you're going to see how that works. To give you a general idea, nitric oxide is primarily used to help with improving vasodilation. They're kind of like signaling molecules. Now, whenever there is a decrease of that, there's going to be more of a vasoconstriction occurring. So it's going to constrict blood or prevent that blood flow. So, or cause high blood pressure. So in this case, Real is an interesting medication because if that is taken, it can work with or without nitric oxide present. Because what happens is nitric oxide has to bind to the soluble guanylate cyclase, turn it on. It's kind of like a switch. It turns on that switch and then causes vasodilation. But whenever there is less of that soluble guanylate cyclase, then it's not going to be enough for nitric oxide and won't turn on. So that would lead to more vasoconstriction. So we'll take a look more into that. Then you got prostacyclin analogs like epoprostenol, treprostinil, iloprost, and then the prostacyclin receptor agonists. We'll look at some of these. So you could see here, I already briefly talked about, you got the ETE, you got the ET1 peptide. In this case, I guess it's a peptide that's produced by the smooth muscle. And normally, under normal circumstances, it would bind to ETA and ETB. And ETB, ETA, it would just balance that vasoconstriction and vasodilation balance. In this case, on the smooth muscle, both of those would cause like vasoconstriction. So, but it would normally just do what it needs to do normally for the blood to flow and get pumped out, as it normally should. But when there's an abnormally high number of ET1, it's going to lead to more vasoconstriction and less vasodilation in the smooth muscle. So some of the treatments here used to block ET1 from binding to these receptors are like ambrisentan and bosentan. So we use this endothelin receptor antagonist to block the ET1 from binding to ETA or ETB, so that it can increase vasodilation. So as I explained, ETB is on smooth muscle. It leads to vasoconstriction. It's the same as ETA, contributes to increase pulmonary pressure, and then letter B or part B or ETB on the endothelial cells cause vasodilation. So I explained the two locations here on the smooth muscle and the endothelial cells. And when ET1 binds to ETB, it releases nitric oxide, prostacyclin, promotes vasodilation. So that's under normal circumstances, it would do that. It helps clear AT1 from circulation. So that's I thought this was one of the interesting mechanisms here. And then you have PDE5 inhibitor. We already talked about a couple of times in the past. You've probably seen a short on it. Now I'm just explaining in a different perspective here. Like sildenafil, tadalafil, like one of those nitrate type of drugs. Um, they actually, as shown here, block the effects of the PDE5 enzyme from breaking down the cGMP signaling molecule to GMP. Because what does cGMP do? It increases vasodilation. That's pretty much all it does, is to block that enzyme from breaking down the cGMP. And then this one is another one, the soluble guanylate cyclase mechanism. I talked about it very briefly, but you can see how there is a bunch of, like on the left side here, very left, the first one here is basically you can see nitric oxide. You can see so many in the smooth muscle, and then you see the little blue circles here. That's like representing like the soluble guanylase cyclase signaling molecules here. And so normally they would turn it on, and then it would increase vasodilation. However, when there is few of those nitric oxide, then how do we turn on the soluble guanylate cyclase? We can't really. It won't allow vasodilation as it normally should. So in order to treat it, we use a stimulator, and the stimulator will help stimulate these receptors, or not, I mean, you can consider them as receptors or like signaling molecules, so that there will be nitric oxide able to bind to these SGC stimulators and allow for that vasodilation occur. Now, these can work even without nitric oxide. So if there's not much nitric oxide, it will still work, because these will just stimulate it, will start working. It will stimulate the production. It will go through and produce GTP, and then GTP convert to cGMP and leading to vasodilation. So that's pretty much all it does. And in a prostacyclin analog, essentially what this one does is very simple. It just binds to the prostacyclin receptor on the smooth muscle and causes vasodilation. That's essentially it. Same thing with the agonist, and that's the whole idea of the treatment of pulmonary arterial hypertension treatments. Just so you can see, it's mainly just to widen that muscle, to make sure that blood flows to the lungs and organs and any part of the body as well.